350 million years. 350 million years. 350 million years. This is when the humanity started. 350 millions. Look at the evolution. 6 million years. 300,000 years. 5,000 years before Christ. When the medicine started talking, mentioning, saying, 400 years before Christ era. First, anatomy studies, Vesalius. First time that the American Code Association decided to do something about the ethical code. 1910. So from 300 million years to 1910. This is recent. Before this date, there was a culture. And listen, we as a doctors, we have this culture. In our historical DNA, in the medicine, we carry these 350 million years of in our culture, in the way that we work. Accountability appears recently, before never existed. And sometimes when we work, when we do medicine, we think like before. So what happened here? One guy, Ernest Coe, this guy did do this. When he was working in Boston, in Mass General Hospital, like a Kekesh number 1, well, Mass General Hospital, no? The guy was fired because he decided to make this. What about if we track all patients? What if we evaluate the results? What about if we analyze the failures? The standard, oh, you're crazy, get out of here. So the guy built his own hospital in Boston. And that was the first time that we started using methods to measure accountability. Before, never happened. And if you analyze, and you see around you, you can see that many people today, they are before this era. So, but this and before and after this guy, 1980s, we are doctors. We believe that we are above of the rest of the people because we are smart, my GPA, Kekesh number 1, I'm gifted. I deserve everything. Could you answer this question? Huh? To? Protect patient. Other opinion? Agree. Other opinion? Standardization. What about to skip my responsibilities? You say no, but what is the reality in our hospital? And we see it as a joke, and we see it like something that is funny. I remember when I came here the first time, they called me from the ER, I was on call, and I was seeing a kid with a wound here. And I saw the fellow of oculoplastic measuring the wound. I say, what are you doing? No, the policy says that if the wound is beyond of 2 centimeters, it's not mine. So it's to protect the patient. It's to shoot the ball out of the stadium. And this is something that we need to eradicate it. We need to learn to assume responsibilities. If you assume the responsibility, you're going to be different. You're going to be successful. Believe me. Believe me. Don't be afraid. So, exactly, to protect the patient from us and to protect us from the patient, not to skip our responsibilities. So, when we talk about all these things, it's because this is the reality. We produce this one. When they touch the patient, we can cure, but we can harm. And happens often. And you know what? It's going to happen to all of us. Because another believer that we have is that, I'm smart enough. You see this guy that he got complications. If you don't drive, you don't crash. And you're going to crash one day. So think in this way. So in the world today, we use 5 pillars to understand and to manage the patients. And this is recent, 1980s, 1990. Before that one, we don't have nothing. Let me show you some examples. Independence. Before was, I'm the consultant. How many times we listen, I'm the consultant, you shut up. This is coming from the historical issue before. Now, this, if you want to QR code it, you are invited, you can picture it. This is a story of a lady in New York that she was taking antidepressant medications. She went to the ER with an anxiety crisis, and the doctor who was working, like sometimes you as a resident working overtime, tired, he indicated meperidine. So the interaction made that the patient passed away. So until that time, we didn't have to. So how often now we discuss in the meetings with the residents that you need to have times of resting after? Well, this is coming recently. Before was, I don't care. You work and shut up. So look at it. These, due to this case, the regulation in the world changed. Before, no recertification. I'm ophthalmologist forever and ever. And if I'm old, better. What happened? For example, in the 20th century, Dr. Sharhill is with us. He's older than me. Have you heard about the intracapsular cataract? I heard like something like a, huh? Well, he did it. Well, probably Dr. Chawan also did. You did intracapsular, Dr. Chawan? You see, we are in the border. So what happened in the cataract surgery was a disaster in the 20th century, because most of the surgeries were performed were intracapsular. You were extracting the nucleus. I saw some of them with the cryo extracting. So the morbidity was terrible. The loss of features was terrible. The retinal detachment were terrible. No microscope. Okay. So based on that, after that appeared all these things, and this is recent. This is recent. Thinking in 350 million of years. No. Look at this one. That was another story. In England, suddenly in a hospital, a lot of people start to pass away. And was related, there was no control at all about the patients that were admitted, there was no monitoring at all. And this result in the development of national safety agencies, okay? So every time that you have certain number of sentinel events, you need to report it. But before, it never happened. So also with the, let's call spongioma. Spongioma, when you are doing surgery and you left a sponge, a compress, was seen. So based on that one, the first time that we started talking about error is human. So that's important. This historical approach makes us understand where we are today, okay? And look at the root cause analysis, safety culture. For you guys, probably it's normal, but before was not absolutely normal, okay? So summarizing, this is the process that I'm summarizing 350 million years in these 2 words, okay? So, let me go here for a moment. Can you please QR code it? Picture it. You can be oculoplastic, doesn't matter. And you can answer. Ready? Ready? You push. You click. This is all the audience that I have? No, I'm going to leave. Got it? You know, once when I asked this question once, the people, many people says no. So we have been witness of these medical errors, okay? And this is something that we face it, and we need to get a learning from that issue. Medical act is an act of trust, and we need to keep it holding this idea. This trust is surrounded by a framework that is legal. For example, you go to US, and probably this legal is the concept of medical act. It's not the trust, it's the legal. But this is a distortion. And probably here in Saudi Arabia, we are moving to that model, and we need to avoid it. Medical act is an act of trust, and we need to keep it with that one. But you have a framework, legal, you have an ethical framework, and you have economical, financial framework, and you have also quality and management framework. This is the way that we work as America, but keeping in the heart of the medical act, the trust. I trust in the patient trusts me. Keep this. Look at this one. Because we believe that the lawsuit happens to other. This is a study published in the Saudi Journal of Anesthesia. Look at how the trend since 2002 to 2018 increased 242%. And you can say, no, this is for other people. No, we're in Saudi Arabia, and this is here. And when we analyze the data, you can see the numbers, but basically you can see how before was the MOH, the main source of lawsuits, and then the private sector. Now the private sector is increasing compared with the MOH. But we are there, we are MOH, or we were MOH, but we are a public sector, so careful with that. We are in the target. We could be sued. You say, well, that doesn't matter. Never do OB. And this is in the world, okay? We are here. We say, well, just 4%, nothing. But when you are this 5%, this is you. You are 100%. So careful with that. Then regarding the claim, well, doesn't matter. You are lucky here that most of the claims are economical claims. In my country, you can go to the jail beyond of the claim. And we need to be careful with these things, because in some points, you say, well, I pay the insurance and I don't care. No, it's not like this. It has sides that we need to be very careful with this one. Okay? Remember these things now. Two. Okay. What happened here? Interesting responses, no? Interesting responses, no? Why is someone who answers admitting a mistake to a patient can give his opinion, his input? Why? Don't feel shy. I mean, anyone who say a mistake to a patient, why is hard for you?
It's like a failure of trust of the patient in you. That's what you can feel when you.
But we are humans.
We are, yes.
Even if you are human, but the patient doesn't understand you are a human. Understand you are a doctor, you have to be.
I agree with what he said.
What do you answer?
I answer that it's harder to admit the mistake to a patient. First, because I don't speak the language, so I cannot express myself properly.
They say Amelia quiz.
In my place, probably it will be harder to admit to myself that I made a mistake, but here to a patient, because I think the patient will not understand me well, but what they said is true. Even if you explain, they expect a very high level of success in your hands. No, the surgery cannot go wrong, and you say, no, it can go wrong.
You know, it's something that we need to discuss openly with the patient. It doesn't mean when you are saying, the patient asks you for give me guarantees, no? Like you are selling a car or,
Yes.
no? And you never fell in this trap. And because you show that you could have complications doesn't mean that you're going to have complications. But you need to explain the reality. We have this, we have pros, we have cons, we have benefits, we have risk. And do it openly. Depending the subspecialty that we do it, there is people that is reluctant to say, glaucoma they know because it's a chronic disease, everyone is going to get blind.
Doesn't exist.
Glaucoma doesn't exist. But you see, for example, anterior segment and refractive surgery, it's funny, you tell the people, listen, there is a complication after a PRK or cataract, and when you say yes, the anterior segment surgery say, no, don't say that because they are going to leave, no, they're going to find another, the competence, no? You need to say that, you need to explain that. Remember, medical act is an act of trust. And you don't be afraid to generate that one. You need to generate trust. If you generate trust, let me tell you something. You generate trust and you communicate correctly and opportunely, you're never going to be, you can have the worst complications in the world and you're going to be in the safe side. Believe me, don't be afraid to do that one, okay? Don't listen people say, no, don't mention that, or don't say that. No, say it. I'm not saying that you exaggerate it, because the patient, when you ask the patient, what the doctor told you? No, the doctor told me I'm going to get blind. No. The message is not that one. You say the truth, but you also say that you have sources, tools, elements to treat the patient, okay? This is pretty old concept. Primum non nocere. You know what is the meaning of this one? Anyone? Primum non nocere. First, do not harm. First, do not harm. And sometimes we forget that when we're in a teaching hospital. I want to do the deep hysterectomy. Yeah, but you don't know how to hold the instruments. But I want to do it. And it's a deep hysterectomy. It's not a patient, a child with glaucoma who has a family, who has a prognosis. No, it's a deep hysterectomy. And sometimes we don't care what happened in the post-op because I have the number. And we need to know if we are capable. So medicine, the first step is primum non nocere. First, do not harm. Are you capable? I'm not saying that I can not harm. It could happen. But if I know it, I cannot do it. I cannot do it. It's simple. Simple equation. So we have these elements to first do no harm. Okay? Communicate. Sometimes, for example, criticism to our institution. The computer is giving the back, you give the back to the patient. Beautiful way to communicate to the patient, no? I'm talking to you and I am here. Okay, what is your problem? You're giving the back. Starting by the body language, we are doing wrong. You need to communicate and communicate correct. You need to create empathy. Empathy means connection. Empathy means that you understand what the patient is having. It's not another patient and get out of here. Okay? So these are the tricks. And the most important part, we're going to make mistakes, but we need to learn from them. Don't be arrogant and think, no, it doesn't happen to me. Remember, if you don't drive, you don't crash. And we all are driving. So, regarding some historical data, 15 to 30% of the ophthalmology malpractice are related to ethical practice. So let's enter a little bit in the ethical point of view. Ethical practice, you can be sued by ethical practices. And it's going to happen. So we need to know about this one. And look at, it's related to informed consent. How many times, I need to change the informed consent, I'm not going to do it. And the hospital is very strict with this one. Why? Because you can be sued. Also, these variables that can take us to be sued by ethical issues. We don't explain, we don't say, you say the things, say clear, and the patient doesn't understand, don't go for surgery. Fortunately for us in ophthalmology, most of the surgeries are not urgent, most. And you need to explain the patient the pros, the cons, the risks, and the benefits, okay? So, look at these details that sometimes we don't pay attention because we're running. We need to do the things fast and get out of here. Take your time for this one. It's important. Okay, look at all these things. The first thing that happens when you get a complication is that the communication is broken. So the patient can forgive you that you made a mistake. And it's going to forgive you that you made a mistake. But if you break the communication, the patient feels abandoned. And this feel abandoned, is the first cause to be sued. Know that you made a mistake. Is that feel abandoned because I break the communication, because I got scared? No, stay with the patient. It doesn't mean that you are assuming that you are guilty or not. It's not about that one. Keep the communication, believe me. Believe me, keep the communication. Don't break the communication. Look at this one. Talking about refractive surgery anterior segment. Any problem with surgery? No, you're going to be fine. The vision is going to be perfect. How many times we see patient, but I cannot see well because expectations here, reality here. So my suggestion is match the expectations. The expectations are not here, or here, or here. Don't do it. Don't do it, because you're going to get in troubles.
What is glaucoma? No glaucoma.
No glaucoma. It's a fantasy. Solamol CPC. But keep this one clearly, okay? Look at this one. You see a patient and a doctor. The doctor is in front of the patient. We need to learn to put it right beside to the patient. No physically. Our attitude should be, I'm right beside you, walking with you, helping you together. No in front of you, no above of you. So right beside to the patient. You are not losing anything because you are walking right beside to the patient. The contrary, patient can forgive you, and it's going to forgive you, believe me. So these things are important to keep it, and don't just to avoid being sued, it's just to do a good practice. Look at the reality. A patient was not warned about dry eye risk, was sued by $2.1 million. Can you believe that? Because I didn't explain. I remember once, during my fellowship, you know, in US you need to explain every detail of the complication, possible complications. And I explain everything, but when you do 8 times a day the same story, I forgot to explain the patient that after strabismus surgery, the patient could have double vision. I forgot. I can say you can pass away, you can be electrocuted, you can whatever, but I forgot to tell the patient can see double. The patient also sued me because I didn't explain that he could see double. And I have bad times because I consider, but this is stupid. Stupid, but you can be sued. So the days that we are coming now in Saudi Arabia, it's a huge transformation. And probably we're going to face that more daily. And we are moving now to research center. We are going to start receiving private patients. This is going to increase, and we need to be prepared for that. We need to be prepared for that. Okay? So these are the things the strategies that we could use to keep this one. All these things, okay? And regarding the legal dimension, other 20% are related to documentation failure. Sounds stupid, documentation failure. We have 2 members of the M&M committee here. What is the commonest discussion in our committee? Documentation failure. And we don't take seriously. For example, I'm going to fill the surgical note. I'm the consultant. You You are who? Arwen. Okay, Arwen. Feel it. And I don't pay attention to that. So the Arwen, I don't know, so probably, no, I'll do later. No? Just imagine for a second that this patient in this moment get complicated. You know what happened? This file record get blocked. You cannot touch it. Go to the court, and the court decide that it's incomplete. Or you do worse. And at night, let me change it. Today is traceable. You have electronic records that can be, you change it. And why you change it? What you were afraid for? And the judge is gonna squeeze you. And we are gonna lose. So be aware of this one. Do it immediately, document it correctly, exactly, timely. That's important. That's very important. Don't take, and take it seriously. You know, don't take it like a joke. So keep with this one, okay? This is what the court says. What is not documented is considered not done. How many times for example, the retroactive charting, we need to be careful with that one. We are facing that one in this hospital. Probably you don't know, but we face these situations, okay? So that's important. That's important. Take your time to this one. If you don't do this one, you're not going to enter to the OR. And they treat us like a kids, like a children. How many delinquencies you have? 30. So you cannot do surgery. So I do the surgery because they are going to punish me. If not, I don't do it. Don't do it like this. Take your time. I know that it's not comfortable. I know that it's not easy, but do it, and do it immediately. It's for your safety. You could say that you are not responsible. No, you are responsible. Probably there is a main responsible physician, but you are responsible. You are touching the patient. You are watching the patient. So careful with that one. Okay? So you remember this one, no? And these guys, they are beautiful angels. No, they never behave during the month. They know that the cutoff time to check the delinquency is the 25th of every month. The day 24, they decide to behave and update, no? And they do click, click, click. Suddenly, click, click, click goes to me. You are an angel, and I'm a delinquent. So you need to understand that this is a chain of things. So every time that you delay, you are generating a problem to others. And just imagine for a second that in this moment, the patient gets complicated. History is going to be blocked. You're not going to get access, and you're going to be in troubles. So that's why the hospital and JCIA insist a lot about the delinquency list. I know that it's a pain in the ass. I know this one, but we need to do it. Okay? So look at the amount of suits that are related to documentation. Again, it's not about that you did a bad, you weren't inobservant or negligent. No, documentation. Documentation. Okay. Look at this one. That's important. So this story, you know this one. So as a message, keep this in your mind. Okay. Regarding the morbidity and mortality, regarding quality, you all see the eminent committee like the court, that we are bad people, bad guys. They are looking for punish you. The consultants, it's funny. They say, "You send me a letter, bro." No, and the main reason and the importance of the quality of management and the morbidity and mortality is to improve, is to avoid failures, is to try to protect the patient day by day better. In our hospital, we are 12 members from the different divisions, different departments, and we have monthly meeting, and we discuss cases. What we do there? So the quality and management department is monitoring the different situations, and they send us situations like lack of documentation, reoperations, complications. For example, when you are writing in the surgical note, complications, none. Perfect. You know what is the difference between ophthalmology and general surgery? that in general surgery, when the surgeon made a mistake, the patient is buried. Our very people is walking and has 2 eyes. And everyone can see these eyes everywhere and say, who did this? Who did this? So your dead people is walking. So in ophthalmology, you cannot lie. Because if you break the posterior capsule, you have a rupture, everyone is going to see it. And you cannot say, no, that was because you were on the camel or you were cooking. Oh, what's your fault? So documented. Complication. This complication can be associated to the procedure, so it's not a problem. Rupture, posterior capsular, is a complication that happened in the cataract surgery. So write it, don't hide it. This is terrible. If you hide this one, again, it's going to be seen. Our dead people has 2 legs and walk. So it's stupid doing this one. So quality management is monitoring it. They check the files, they see, they have the system, and they presented to us with this idea. And this is the format that we have. We receive this one, and we have a case, for example, a patient that was operated and has a remanent nuclear material after a phaco, no? So it's supposed that the surgeon entered to do washout, but the patient, the medical doctor never documented what was the reason to enter to the OR and to justify why you are doing the surgery. This lack of documentation can be a cause of lawsuit. But from the quality and management point of view, we're not doing the things correctly. So how can we avoid, now that you have remanent of, how can you document that one? Because we, as a committee, we check trends. Let's suppose that Dr. Sema every week, every month is going to with cases from him to this committee. Something is happening with this doctor. Something is doing wrong, Dr. Sema. Probably we need to see it and see if it has any problem, if it has lack of training, lack of experience, is passing by a personal problem, whatever. The point of view is not punish, it's about what is happening and taking actions to avoid that being repeated. So this is the things. And we say if the patient has predisposed, not predisposed, undetermined, acceptable, unacceptable, and then if this person who is revising this one, who usually is member of the same division, send us and we discuss it. And what are the solutions usually? Or people believe that say, fire him. No, we don't have this capacity. It's not in the scope of the committee doing this one. What we say, usually we say in this.
Yeah, send a letter and remind that documentation has to be such and such and such.
Do we have punishment capacities? Do we have the scope of the committee is being blaming and punishing? So this.
If you allow me.
Yeah.
But the committee, when we review some cases, for example, DS, deep splenectomy, one of the big things that happens when you are getting trained is to have a membrane, trabecular desymmetric membrane break. That is not a complication. That is an event that happens and you convert into a trabeculectomy, gold standard. So through the committee, we were able to remove that complication till then to a non-complication. It's part of the procedure. So,
For example, retina. How many times we discuss patient use silicone oil and silicone oil overfilling and it's inducing high IOP. And these cases come to the committee and say, hey, well, we are discussing is something it's going to happen or could happen, so, and it can be managed. So we check if the management was correct. Second, for example, in this case of the overfilling with silicone oil, we can recommend the creation of guidelines. And Retina Division at this moment is creating these guidelines to see how can we standardize to avoid the overfilling and that this situation happen again or happen often. Okay, so that's the concept of the M&M committee. So we do like this, and we do recommendations. Recommendations to whom? Recommendations to the Quality and Management Department, recommendations to the medical director, recommendation to the executive committee, or recommendation to any department that we consider they should. But in none of these issues, we are the court. So it's just to, if you one day you receive a letter, don't feel, why you, Dr. Sema, you're against me. No, it's not nothing personal. It's related to these particular issues, okay? So we do all these things. This is our job. This is the work that we do, okay? You don't see any word punish, blaming. People here, sometimes it's sensible, no? You're against me because you sent me. It's about facts. It's about situations. It's not personal. If you feel guilty, that's another problem. But I'm not judging you. I'm just telling you what is happening, how can we avoid this to happen again. Basically that one, okay? So we also can suggest the creation of KPIs. Also implementing policies, guidelines. This is the job of our committee. Again, look at all the impact that we can have it because our work. This is the idea. Non-punitive culture. Non-punitive culture. Non-punitive culture. Forget about that one. Please, believe me. It's like this. So this is the final goal of any of these committees here and in other hospitals. And careful with this one. I mentioned it, just the syndrome of the last patient. I think that we discussed with my friend John Taylor. John Taylor. You know the story of John Taylor, no? He can tell you the story of John Taylor. So the syndrome of the last patient, long day, we are tired, no? And then do like in the movies. You see this stereotype of the movies? People is tired, and usually they open that one and do it once, no? You see that? And he watch to the mirror. He refresh himself, and then he kill 100 persons, you know, in the movies, in the Hollywood movies. But we have been in this situation, and careful with the syndrome of the last patient. This is, I'm tired, and this last patient is the patient who is going to have the retinoblastoma, who is going to have the optic neuritis, who is going to have the... So if you are not in capacity to see this patient correctly well, do this one. Take 5 minutes, go, wash your face, ask for help. If you are not sure, reschedule the patient, but don't leave the patient, because this is an important source of complications and morbidity and mortality. So remember that one. Suggestions. I tell this to all the residents and fellows that work with me. When you have doubts, overdo. When you do this one, every time you're going to be in the safe side of the equation. Doubts, overdo. No underdo. No shoot the ball. What's the name of the defender? What's the old defender of Real Madrid? Ramos, Sergio Ramos. Don't become Sergio Ramos at everything. Shooting the ball, no? Don't do that one. Don't do that one. Don't do that one. I know that you are going to do it, but don't do it. Care over speed. We have sometimes pressure. If you are in the ER, they push you. And something that is funny in the ER, probably 60, 70% are not emergencies. Are people that they don't have appointment, appointment, no, yes or no? 90. So you see 150 patients and probably 140 are, so, and they push you. And so take your time. Take your time. Because if you get complicated, nobody's going to say, oh, he was very fast. You're going to be fast when you work with me. And the 3 words that are going to help you every time. Ask for help. You have doubts, ask. 3 magical words. Ask for help. Sometimes we are, no, I cannot ask because they are going to think that I'm a dummy, that I'm retarded. I remember when I was in the fellow, you know, my mentor was a cowboy. Was speaking, you know, hey, yo, well, I mean, like a cowboy. Sometimes understanding him was difficult. And he was talking to me and I was saying like, and I told him, don't think that I'm retarded. It's just that I don't understand you. So doesn't matter that people think whatever they want to think. If you have doubts, ask for help. And do your job. Don't shoot the ball out of the stadium. And the most important part is documented. How many times we are on call, Dr. whatever from Dr. Charles from anterior segment told me, from glaucoma told me, that do this, and this. And you write it, or sometimes we don't write it. And sometimes Dr. Charles never write it. It's not documented, you document it. If he doesn't document it, doesn't matter, you document it. Believe me, we saw situations here where the problem is documentation, and do it properly, correctly, and timely. One practical case. Do you think that this is possible? So, it's possible. Patients that have been referred as an anisotropia. How many times I see for you that say, no, but the medical report says. What I say about medical reports, don't believe in medical reports. Don't believe in medical reports. Check by yourself. Check by yourself. How many times you are on call? It's a kid, I'm not going to see it. Call the fellow. We become referentiologists. We don't see the patient. We don't check the patient. Check the patient. Don't believe in any medical report. How many referrals we receive as a rule out retinoblastoma? And it's because they want to refer. So our colleagues, and many colleagues that we train here, they become later in liars, sending us lies, which is an ethical issue. No? You are lying, just do whatever you want. In private, no, go to case number 1, put whatever, and we have the obligation. Check your patient. Khaled. Where is Khaled? You know who's this guy?
This is Mr. Taylor.
Huh?
John Taylor.
Okay, anyone knows the history of John Taylor? Probably you, can you tell us with history? I would say that John Taylor is a TikToker, is a Instagrammer, or is a YouTuber. Today we have the trend to believe in any stupidity that we see in the social media. This doctor is famous, has 1 million followers. We don't know if he's really a good doctor or not, but we just, because 1 million, are we stupid or what? So this guy was like a YouTuber of the Middle Age. Can you tell us something about John Taylor? Well, this guy is pretty interesting, and John Taylor, I think that you can, this is a YouTube, talking about YouTube, no? The YouTube link that tell the story about John Taylor, no? It's a guy that is talking. Well, this guy is a YouTuber of that time, TikToker, famous. He was in a car with a horse, no? And say, John Taylor ophthalmologist, walking for all Europe. This guy, for example, operated a George Friedrich Handel from cataract. And at that time, the cataract surgery was about reclination of the lens. They were pushing the lens to the retina, so the patient was aphakic. Good. Well, Handel developed a terrible sepsis and passed away. Handel, the musician. People says that operated one of the kings of Inglaterra, from England, and also was very close to the Pope at that age. This guy was for the towns, as you were mentioned. I'm going to operate the alternating isotropia. So he was grabbing one eye, cutting the conjunctiva, and patching the eye. What happened if I cut the conjunctiva and I patch the eye here? What's going to happen with this eye? It's going to be straight. So the guy was saying, okay, keep the patch for 3 days. Well, the people, wow, the eye is straight. The day 2, the guy was leaving the town. So was a fake doctor, was a terrible doctor. So, home message. Our city, our country, our world is plenty of John Taylors. Beyond of that, we can be John Taylors. So, careful. Check every patient. See the patient to avoid these situations. Okay? So, this is important. We can make mistakes. No problems with making mistakes, but we need to learn from our mistakes. I'm going to tell you a story, a case. In Venezuela, 17 years ago, was a doctor, the retina specialist, that has a patient with angioides striatus. The patient developed macular edema, so the indication was Avastin. At that moment, Avastin was the medication, and this medication was prepared in pharmacy, and at that moment, bilateral injection was given normally under, asepsis. And so this retina doctor was traveling, so called another colleague. I need to travel, can you put the injection to this patient? And okay, so this doctor, in OR, antisepsis, inject the patient. 3 hours later, the patient called this doctor saying, I cannot see, and I have a lot of discharge. Immediately, the patient was taken to the clinic, then to the OR. The patient developed an endophthalmitis by Enterococcus fecalis. So, intravitreal vitrectomy. The day after intravitreal vitrectomy, well, the patient, because the condition, the patient developed a sepsis, and 3 days later, the patient passed away. So let's analyze this one. Let's suppose that we are the M&N committee. What do you think? Any suggestion, anything that you can?
Every time we try.
Since the condition is not urgent, they can be taken through the appointment.
But the primary was living for a month. Why inject those? A good question, because usually you should do it separately. At that moment, what the indication was, they do it like when we do bilateral surgeries here. No, we do separate the field. Was doing in OR, but good question. So you think that doctor made a mistake with that one? Other opinion. Let's suppose that we are in M&N committee. We have this case. Enterococcus fecalis. No. The bottle, there were like 7 patients also in other places contaminated with endophthalmitis also. I forgot to tell you that. Somebody in the pharmacy made a mistake, no?
Maybe the product is contaminated itself, so you have to contact the company, ask them about it.
So my question is, let's think as a M&N committee. Was preventable this one? Absolutely preventable? What is the other? The other aspect that we measure?
Out there, I don't know, patients in the same day with other doctors, doctor informatics, because it's not mostly the problem with the clinic of the doctors that give the injection, or the sterilization exactly. The other problems, for example, all patients have not informatics.
Okay. What do you think about the probability to get sued of this doctor?
High,
Very high.
it's very low because he's dead.
Huh? What? Huh? Well, the family, of course. Do you think that it's a high probability? Any other comments regarding this one?
The recommendation is when you go to the toilet, wash your hands.
Yeah. But what's not the doctor?
No.
What's coming from the Avastin? No, it's supposed that was prepared in safety.
No.
So, I was a doctor. And I spent 3 months, I stopped to work. I was doing a favor to a friend, and Eric. And I said, can you imagine? I was doing intravitreal injections. The only thing that was making me mad was about the bilateral injection. No? And you know what? The patient and the family never sued me. I kept with the family right beside, walking with them, being clear, not showing fear, showing that, we have a complication, but we are going to do the necessary things to help you. So I was holding this patient, this family. the learning of this, the learning home, I mean, I learned the lesson, and we have discussions in the division sometimes when, no, let's do bilateral catheter. I just say, you know, I prefer to have higher risk of anesthesia than, you know, I passed by this once and I don't want to pass again by this one. So we can kill people. I'm not calling that I'm a murderer, no, but we can harm. And we can harm without intentions. I didn't have the intention to, oh no, I was not the guy who was doing this one, no? But I stopped my clinic. I went to, I asked for help, because can you imagine, no, you're doing a favor and you finish with this story. So this is a reflection that we all can be in troubles. Don't be arrogant and think, oh, because my GPA, no, forget about all these stupidities. Because I'm a professional, forget about these stupidities. Because listen, happened to me, and look at this one. One person passed away because of this one. Okay, so keep it. This one, this is the thing that we need to eradicate from the mentality of M&M committees. We have this trend. I don't know why we think in punishment. We think in, if I don't put disciplinary action, all of you, if they don't tell me disciplinary action, I don't act. No, we are adults. And the M&M committee is not this one. We need to cancel this vision. This is my mission as a chairman and the committee. We all are in this line to cancel this vision. Of course, that is not, I mean, it's not pleasant to be called by someone. But if I receive some message from the M&M committee, let's try to learn from this, because this is the real message. We need to learn from our mistakes. We need to learn from our mistakes. For example, I never use, again, Avastin. I never inject any patient with Lucentis, any no? And this was a terrible lesson for me, but taught me that we need to respect our patients. We need to respect what are we doing with the patients, okay? So this one is important. Communication, do your job, document it, be empathetic. And last question. What do you think? True or false? If you tell me true, I'm leaving, I'm not coming back to okay. This is our goal. This is our mentality. This is our structure as a hospital, okay? These are the words that says and mention about M&M committee, okay? Thank you very much.